You know, it's funny how we often think of our minds and bodies as, well, kind of separate things running on different tracks.
Yeah, like two different systems entirely.
Exactly. But when you really look closely, it becomes so clear how deeply interconnected they are.
Absolutely.
Sometimes those physical symptoms, the aches, the pains, that fatigue that just won't go away, or even things that look pretty serious neurologically.
They can actually stem from really complex psychological roots. It's fascinating.
It really is. And navigating health stuff is confusing enough, right? But when these kinds of mind-body connections are involved, it can feel, well, overwhelming, like being lost in a fog.
That's a good way to put it.
So that's why we're doing this deep dive today. We want to get into a specific set of conditions where this link is, like, front and center.
hmm We're going to explore what are known as somatic symptom and related disorders. We'll be using a specific framework that helps make sense of them. And within that, there are really four main conditions we'll focus on today: somatic symptom disorder, illness anxiety disorder, conversion disorder, and factitious disorder.
Got it. Four key ones. And our mission here really is not just to throw definitions at you.
Right.
We want to help everyone listening get a real handle on what makes each one distinct, the key features, and importantly, how they differ from each other.
Think of it as hopefully a clear guide through this often misunderstood territory.
Yeah, bringing some clarity. So let's jump right in. Where should we start? Maybe with somatic symptom disorder.
Sounds good. Let's start there.
Okay, so somatic symptom disorder. What's the core idea here?
Well, essentially, it involves someone having one or more physical symptoms. And these symptoms are genuinely distressing, or they cause significant disruption in the person's day-to-day life. They're real symptoms.
Okay, real physical feelings, but what's the twist?
The twist, or the key psychological aspect, is that there are also excessive thoughts, feelings, or behaviors tied to those symptoms. It's the reaction that's disproportionate in a way.
Ah, okay. So it's not just, say, having fatigue. It's more about the mental energy around the fatigue.
Exactly. It could be persistent thoughts about how serious the symptom might be, way out of proportion to perhaps what doctors are finding.
Or maybe really high levels of anxiety about their health in general because of that symptom.
hmm Or even just dedicating an excessive amount of time and energy to the health concerns, constantly researching, going to appointments, talking about it, that sort of thing.
Right. And the text mentions something about duration, doesn't it?
Yes, that's
Ah,
important. While the specific symptom might change, maybe it's headaches one month and stomach issues the next, the state of being symptomatic and having these intense associated thoughts and feelings is persistent. It needs to last for more than 6 months.
6 months. Okay. So it's a chronic pattern,
Mm.
even if the specific complaint varies.
Precisely. And there's also a specifier mentioned if pain is the main issue.
Oh, yeah. What's that?
It's called the predominant pain specifier. It's just used when pain is, the primary focus of the clinical attention and the excessive thoughts or behaviors.
Gotcha. So maybe an example would help. Like, someone has persistent back pain, they've seen doctors, maybe tests are inconclusive,
Okay.
but they spend hours every day researching rare spinal conditions online. They're constantly telling family how worried they are. It's something terrible. Maybe they've stopped working because of it. That kind of picture, where the reaction seems much bigger than the objective findings.
That's a very good illustration. The focus on the excessive thoughts, feelings, and behaviors related to the symptom is key.
Okay, that makes sense. Now, how does that compare to the next one? Illness anxiety disorder. You mentioned that earlier.
Right. Illness anxiety disorder. This is where the focus shifts subtly, but importantly.
Shifts how?
With illness anxiety disorder, the main thing is a preoccupation with having or acquiring a serious illness. But here's the key difference. The person generally doesn't have significant somatic symptoms. Or if they do, the symptoms are quite mild.
Oh. So unlike the last one where there are distressing symptoms.
Exactly. Here, the anxiety isn't primarily about a symptom they're currently experiencing in a severe way. It's more about the fear of illness itself, the fear of what might be wrong or what they might develop.
So the anxiety is the main event, so to speak.
Pretty much. There's a high level of health anxiety, and you see this manifest in a couple of ways.
Like what kind of behaviors?
Well, often excessive health-related behaviors. Things like repeatedly checking their body for signs of illness,
Yeah.
looking for lumps, size, any little change.
Constantly scanning.
Yes, or constantly seeking reassurance from doctors, friends, family. Sometimes they might even doctor shop, hoping someone will finally find the serious thing they're convinced is there.
Or the opposite. Does avoidance happen too?
It does. That's the other side of the coin, maladaptive avoidance. Some people become so anxious about finding out they are sick that they avoid doctors, hospitals, or even reading about health topics altogether.
Wow. So either hyper-focused or completely avoidant, driven by that core fear.
Precisely. And again, there's a time frame. This preoccupation with having an illness needs to be present for at least 6 months.
6 months, like the other one.
Yes, but an interesting point here is that the specific illness they're worried about might change over that time. It could be cancer 1 month, heart disease the next, maybe an autoimmune disorder after that.
But the underlying anxiety about being seriously ill persists.
That's the constant feature.
So an example here might be someone gets occasional mild tension headaches, nothing severe,
Okay.
but they become absolutely convinced it's a brain tumor. They spend hours on medical websites, keep asking their partner if they notice anything strange about them, maybe demand MRIs despite doctors saying it's unnecessary. That level of fear with minimal symptoms.
That fits the picture of illness anxiety disorder very well. The anxiety is the dominant factor.
Okay, that distinction is becoming clear. Now, what about conversion disorder? That one sounds quite different. It has another name too, right?
Yes, it's also called functional neurological symptom disorder. And you're right, it presents quite differently.
How so? What are we looking at here?
Conversion disorder involves symptoms related to voluntary motor or sensory function. So we're talking about things that look like neurological problems.
Like actual physical changes.
Yes, things like weakness or paralysis in a limb, non-epileptic seizures or seizure-like episodes, sudden blindness or tunnel vision, loss of voice, difficulty swallowing, numbness or loss of sensation. Really striking symptoms.
Wow. So it really mimics a neurological condition, but what's the catch?
The absolute crucial part, the diagnostic linchpin, is finding evidence of an incompatibility between the symptom and recognized neurological or medical conditions. Okay. Meaning that after a thorough medical workup, neurological exams, tests, imaging, there's no known neurological disease or other medical condition that can actually explain the symptom the person is experiencing. The wiring seems okay, but the function is impaired.
So the physical symptom is real, the person isn't faking it, but the usual medical causes aren't there.
Exactly. The symptom is real, it's causing significant distress or impairment in their life.
That must be incredibly frightening and confusing for the person.
Absolutely.
Yeah.
Imagine suddenly not being able to see or move a limb, and doctors are telling you they can't find a physical reason why.
Yeah. Now, the text mentions specifiers again. What kind of details do those add?
They just help describe the presentation more precisely. You can specify the symptom type, like with weakness or paralysis, with abnormal movement, like tremors, with anesthesia or sensory loss, and others. You can also specify the duration, acute, if it's less than 6 months, persistent, if it's 6 months or more. And importantly, you can specify if the symptom onset seems linked to a psychological stressor, with psychological stressor,
Right.
or without psychological stressor.
Right. So going back to an example, maybe someone witnesses a traumatic accident and then suddenly finds they can't speak. A doctor checks their vocal cords, everything looks physically fine, neurological exams are normal.
That could potentially fit conversion disorder, perhaps specified as with speech symptom and with psychological stressor.
Got it. That makes sense. Okay, moving on then. The last one in this group is factitious disorder. This one seems to involve, well, deception.
Yes, factitious disorder is where the element of intentional falsification comes in, but the reason for it is key.
Okay. And there are two types mentioned, imposed on self and imposed on another.
That's right. Let's start with factitious disorder imposed on self.
What does that look like?
Here, the individual deliberately fakes or produces physical or psychological signs or symptoms. They might lie about symptoms, tamper with tests, or even injure themselves to create signs of illness.
So they are actively making themselves seem sick.
Yes, they present themselves to others as ill, impaired, or injured. But here is the absolutely critical point.
What's that?
This deceptive behavior occurs even without an obvious external reward. There's no clear payoff, like getting money or avoiding work.
Huh. So why do they do it then?
The motivation seems to be internal. It's thought to be driven by a psychological need to assume the sick role, to be seen as a patient, to get attention, care, sympathy associated with being ill.
Okay, that's a really crucial distinction, the lack of external gain.
It is. Now, compare that to factitious disorder imposed on another.
This sounds worrying.
It is very serious.
Right.
Here, someone, usually a caregiver, deliberately falsifies or induces illness in another person, typically someone dependent on them, like a child, or maybe an elderly adult.
And they present this other person as being sick.
Yes, they present the victim to doctors and others as ill, impaired, or injured, often leading to extensive and unnecessary medical investigations or treatments for the victim.
And again, the motivation for the perpetrator isn't an obvious external reward.
Correct. For the person doing the falsifying, there's no apparent external gain. The motivation, again, seems to stem from their own internal psychological needs, perhaps related to interacting with the medical system or being seen as a devoted caregiver.
Wow. And the text mentioned different ways this falsification can happen. It's not just lying.
No, it can range from simply feigning symptoms to exaggerating minor existing ones to simulating complex conditions or, most disturbingly, actually inducing illness or injury. This could involve poisoning, suffocation, infection, or self-inflicted wounds passed off as illness signs.
That's deeply disturbing. Okay, now this leads directly to a really important comparison the text makes. Factitious disorder versus malingering. You hinted at this difference in motivation.
Yes, this is a vital distinction to grasp. Both involve intentionally producing or faking symptoms, but the why is completely different.
So malingering is...
Malingering is the intentional production of false or grossly exaggerated symptoms, but it's always motivated by a specific external incentive.
An external reward. Like what?
Things like trying to avoid military duty or work, getting financial compensation like disability payments, obtaining drugs, especially opioids, or evading criminal prosecution. There's a clear, tangible goal.
Right. So factitious disorder, internal psychological need for the sick role. Malingering, external, tangible goal.
You've got it. That's the core difference.
And are there clues, like red flags, that might suggest someone is malingering rather than having factitious disorder or a genuine condition?
Yes, the text points out a few things that should raise suspicion for malingering.
Such as?
Well, the context matters. If the medical evaluation is happening because of a lawyer's referral or pending legal action, that's one flag.
Okay, what else?
A marked discrepancy between the person's reported symptoms and objective findings on examination or testing. If what they say they feel doesn't match up with what can be measured or observed.
Inconsistencies. Makes sense.
Also, a lack of cooperation during the evaluation process or not following through with recommended treatment once it's offered. And finally, sometimes a history of antisocial personality disorder might be present, though obviously not always.
So it's really about looking at the whole picture, the circumstances, the consistency, the behavior, and the potential external drivers.
Exactly. Motivation is key.
Okay. So given how complex factitious disorder is, especially that internal motivation, what about treatment? The text mentions it's challenging.
It is very challenging. A major hurdle is that individuals with factitious disorder rarely seek treatment for this problem specifically. They often lack insight.
So they don't see their behavior as the problem.
Often not. Or they are too invested in the deception. So therapy, if it happens, is usually prompted by family members who've noticed things don't add up, or sometimes through court orders or child protective services in cases of factitious disorder imposed on another.
And is there, like, a go-to therapy that works?
Unfortunately, no. The text is clear that no single treatment has proven consistently effective across the board.
So what do experts recommend?
The consensus, sort of expert opinion like that cited from Huffman and Stern, really emphasizes building a strong, trusting therapeutic relationship first.
Building trust seems crucial if there's deception involved.
Absolutely. And using supportive therapy approaches, focusing on managing the person's distress and improving their overall functioning, maybe without directly confronting the deceptive behavior right away, which can be very tricky.
Kind of working around the edges first.
In a way, yes. And consistency of care is vital, making sure all the doctors and therapists involved are communicating to avoid the person playing one off against another or getting unnecessary procedures.
So patience, support, consistency, and building trust seem to be the main strategies, even if a cure is elusive.
That sums it up well. It's often about management and harm reduction.
Okay. Now, speaking of understanding all these distinctions we've been making, the text had a specific tip, almost like a study note.
Ah, yes. It's a really useful takeaway, actually. Whether you're studying for an exam or just trying to understand these conditions better for yourself or someone else.
What was the tip?
It literally says, for the exam, be sure you can distinguish between somatic symptom disorder, conversion disorder, factitious disorder, and malingering.
And that really does nail it, doesn't it? That's kind of the core task we've been working through here.
It is. Being able to tell them apart based on, well, are there real symptoms? Are they medically explained? And what's the person's apparent motivation, internal need, or external gain?
Yeah, getting those differences clear is fundamental.
Definitely. So just to quickly run through them one last time, somatic symptom disorder, real distressing symptoms plus excessive psychological reaction.
Got it.
Illness anxiety disorder, high anxiety about having an illness with minimal or no symptoms.
Right.
Conversion disorder, neurological-like symptoms but no compatible medical findings.
Right.
And factitious disorder, intentional faking or producing of symptoms for an internal psychological need.
As opposed to malingering, which is faking for an external reward.
Exactly. You've got the key distinctions.
These are definitely complex conditions,
Yeah.
and hopefully this discussion, based on the framework we used, gives people a clearer foundation.
It really highlights that powerful, sometimes baffling link between mind and body, how thoughts and feelings can genuinely shape physical experience.
It really does, which I guess leads to a final thought maybe, something for listeners to chew on.
Go for it.
Well, building on what we've discussed, how might our, broader culture, our beliefs about illness, maybe stress, or even individual life experiences, how might those things shape how these mind-body conditions actually show up?
Oh, that's interesting.
Yeah, how they're expressed, how they're understood, maybe how they're treated, both by the person experiencing them and, by doctors and society.
That's a really thought-provoking question. How the context influences the manifestation and perception of these deeply personal experiences. Something definitely worth considering further.